Welcome, everybody. My name is Jill Jonathan. I'm with Red Wine and Blue. We're a community of women who use digital media and friend to friend organizing to change the world one suburb at a time. And we like to talk about real things. So today we are going to be talking with Christine Pearl, who is with Red Wine and Blue. Joe, as in JoJo from Jers, will be joining me as always. And then we'll be talking to Dr. Griffin, who is Christine's doctor. And the thing we're talking about is endometriosis, which affects 1 in 10 women. And the more I'm learning about this, the sadder it seems. It's like women will go through this pain for years before it's diagnosed and treated properly. So we just felt like, and March is awareness month for endometriosis. So we thought today was just a great time to just talk about it and find out more about it. So if anybody's struggling with this, they don't feel alone. You're not alone. And also, I just want people to know that we believe you. And if you're in pain, then you need to advocate for yourself. So excited to bring everybody else and get started. Thanks for joining. Hey, Christine. Hey, Joe. Hey, Dr. Griffin. Thank you so much for joining. And Christine, let's just start with you. I'm sure you could talk about your story for hours, but just give us just like a little synopsis of your story and what you've been dealing with.
Sure. So when I was about 12 years old, I think is when I first got my period for the first time. And I remember having like a discussion with my mom right away where she was like, in our family, things are pretty brutal. If you're not feeling well, please talk to me. We'll figure out how to handle things. And right away, like my first period, I was in bed for like 3 days. And as a seventh grader, like, you don't know how to handle that. You don't know what's going on. And, my mom was never officially diagnosed with endometriosis, and she passed away before I was diagnosed. But I suspect, just based on the infertility issues that she had, that she probably had it too. So all throughout high school, I was missing school twice a month at least for the first 2 days of my period. And I was like on the honor roll and in, all AP classes and everything. So it was really difficult. And my mom taught in her school district too. She's like, you cannot keep missing this much school every day or every month when you're not feeling well. Um, so we went to my doctor, and she's like, some women just have worse periods than others. And even though you're, bleeding heavily and you're throwing up from being in so much pain, and you can feel yourself ovulating. So the pain wasn't always just when I had my period. It was pretty constant. Um, so they put me on birth control and called it a day. That was what they were going to do to fix it. But as wonderful as birth control is, because it lets women decide when and if they want to have kids, it also comes with its own side effects, right? So emotionally and physically, I wasn't quite feeling like myself, but I knew what the alternative was. So I kind of just chose that as the lesser of two evils. And through college, I went to college in Ithaca, and I double majored. And through that, like, it was still not perfect. Like, I was still much sicker than even my college roommates. Like, 5 of us girls lived in one apartment for my last 2 years of college, and I was the only one that was like taken out by it every month, right? Even on the pill. Um, so I kind of always in the back of my head knew something was wrong, but when I went to just like my annual OBGYN appointment, she would say, like, have you tried ibuprofen?
You're like, no, I didn't think of that. Thanks. Okay,
That
good. All good now.
or like vitamin C. And I was like, I don't think you understand that this is literally destroying my life, right? And then I took a year off between undergrad and law school. And during law school, it got so much worse. So around then, I was probably 24 to 27, give or take. And it was just getting progressively worse. And around the same time, I kind of realized, hey, maybe I don't want to be on the pill all the time. Like, I don't like what it's doing to my mental health. I don't like how I'm feeling. So I experimented a little bit with going on and off of it. And mentally, I was so much better. But then physically, I was just like sick when I was ovulating, throwing up when I was ovulating, throwing up when I had my period, bleeding through pads like crazy, having to like use period underwear and a pad, having to sleep on a towel at night, having to wake up in the middle of the night because I knew that I couldn't sleep for 8 hours. And I was just miserable. And every time I brought it up to my OBGYN, she was like, you just lost the lottery, basically. Sorry. So she actually ended up referring me to another doctor, and I asked him. I had been Googling around that time, and endometriosis kept popping up as a possibility. And this doctor told me it didn't matter if I had it or not because his treatment for heavy bleeding was the same no matter what, and it was an ablation. And Dr. Griffin can speak a little bit more about that, I'm sure, because I'm not a doctor. And something in my gut just was telling me, like, this is not the right decision to make. So around my 30th birthday, I finally found an endometriosis specialist in Western New York where I live, and he did my first excision surgery and diagnosed me. And I remember waking up, it was my first surgery ever, so I was super concerned about, the anesthesia and all of that stuff. And waking up, the first thing I asked the nurse was, do I have endo? Because if I don't know what the answer is anymore, but I
Right.
can't keep living like this. And I've been gaslit so much that I thought I was, going crazy. But when she told me that it was endo, like, the relief I felt that it wasn't just all in my head and I didn't have a low pain tolerance, and it wasn't just law school stress, it wasn't just the bar exam, it was an actual physical thing that was wrong with me, was so relieving. Um, so, and then 3 years later, I still wasn't feeling great. And I realized I've never wanted children. That was just never part of my plan. But every doctor that I've spoken to would not consider any sort of permanent solution, because what if I get married and change my mind? What if this hypothetical husband that may or may not ever exist, decides we want kids and I can't do anything about it? So finally, I found Dr. Griffin, and he agreed to do a hysterectomy. And I'm about 2.5 months post op now, I think. And I have never felt better in my entire life. Like, not having to worry about getting my period every month, not having to plan, trips, not having to plan work events, not having to do all of that around my period that was controlling my life for so long, is liberating. And given what's going on in our country right now, as an attorney, like, I know what the end goal is with the Roe stuff, right? So now I never have to be forced to have a baby either. So, like, that's a nice added bonus to not feeling like garbage at least twice a month. So that's kind of my story.
Dr. Griffin, is this pretty normal with some patients you see? Christine's story, have you seen this a lot before?
It is, unfortunately. So, it's Christine's story is definitely not atypical. Endometriosis is one of those conditions that can certainly take a long time to be acknowledged and for sure diagnosed. And then the treatment options, I think, are sometimes very limited depending on the physician you see and what their area of expertise are. So, but what you described, I think, is very typical. And I guess, back it up a little bit to explain what endometriosis is a little, and talk about the condition, how it progresses. But endometriosis, it's a condition of women because it refers to endometrial cells, which are the normal cells that line the inside of the uterine cavity. So those cells are called glandular cells. That means they respond to the hormones of the menstrual cycle. So every month, they grow, divide, are getting ready to set up for pregnancy, essentially. If you're not pregnant, your hormone levels drop. Those cells then shed and come out as the menstrual blood, and the process renews itself. So endometriosis is when those normal cells that line the inside of the uterine cavity, they migrate outside of the uterus, and then they can implant and grow on other surfaces inside, most commonly inside the pelvis and abdomen. And so once they reestablish themselves in the wrong place, they're still going to do what they're programmed to do. So they still are exposed to the same hormones of the menstrual cycle that grow, divide, and they shed. But instead of shedding and coming out as menstrual blood, they shed within the abdominal cavity, and your body doesn't like that. So it recognizes them as foreign, it mounts an immune response, and that whole process of trying to kind of clean up itself, it can be very painful. So pain is one of the principal ways that presents. So it's a disease that typically starts around the time of the menstrual cycle start, is when the disease sort of gets going. And then it becomes, one of the hallmarks of it is that it becomes progressively worse over time. And so it's difficult, with women, you only have yourself to really compare to. You can talk as much as you can talk, but your experience is very unique. And so I think it is sort of blown off, for better word. It's unfortunately just dismissed sometimes as saying, well, that's just what you have to deal with. And, as it becomes progressively more and more disruptive to your life and your daily activities. And so once it does start to become disruptive, where you're missing school, work, then I think it's time to really investigate a little further. So, but as far as treatments go, it's also very typical just to be thrown on a birth control pill. The way that we treat endometriosis, there's two main ways to go. And one was hormonal suppressive therapy. So anything that takes away the highs and lows of the menstrual cycle can also take away the growth and then shedding and inflammatory response of endometriosis. So for a lot of women, it can be a very effective treatment at first, and sometimes for the long term. I don't know if that's not my own thing, but anyway, the birth control pill essentially just sort of gives you those hormones in steady states. You're not getting this growth and then regression. It's just more so this constant. And we can give them a couple different ways. It sounds like, Christine, you were initially giving them so that every month you were still having withdrawal bleed. So you're taking the active pills and stopping them, during which you have that drop in hormone levels that causes everything to shed. We actually now try to use them in continuous use, meaning we can prescribe the pills in such a way where you're taking the active pills for 3 weeks, you skip that placebo week, and you go straight into the active pills of a second pill pack. And I have some patients who can do that indefinitely. And, there's no medical reason why you have to have a menstrual cycle every month. So you can effectively go without a period for months and even years at a time. Some women experience breakthrough bleeding and have to have an intermittent withdrawal bleed every few months. But sometimes we try to space those cycles out as far as we can, just so it's not debilitating during that time frame. So, and there's other hormonal treatments that we can talk about, but the other mainstay of treatment is surgery. And unfortunately, that's the only way we have to really make the diagnosis as well. Because endometriosis, we're a lot of times making this diagnosis based on clinical suspicion, kind of the story that Christine explained, with progressively worsening condition where pain often precedes your menstrual cycle, is worse with full flow, but can also present other times, either with ovulation, with intercourse, with exercise, certain things that provoke it as well. So a lot of times we're very suspicious, but we don't know for sure until we actually go in and look with a diagnostic surgery. Unfortunately, we are yet to develop a blood test or imaging study or biopsy or anything else we can do ahead of time before we take that step. Sorry, it's a lot of me talking. I can slow down.
I wanted to thank Christine for sharing this story, and thank you, Dr. Griffin, for sharing your expertise, because I confess, which is shocking to me at 48 years old, that I don't know much about endometriosis at all. And I'm the mother of a soon-to-be 10-year-old girl who will be entering this phase of her life. And what I find so fascinating is that 1 in 10 women or young girls experiences this, and yet I didn't know about it very much, and it's not talked about very much. And then as I'm reading about it, something Christine mentioned, which I'd never even heard the term medical gaslighting, but now that I'm reading more about it, of these women that were made to feel like the pain was like in their heads, or that they were crazy. And then I was reading about, women who said that they were made to feel like it was their fault. So it's a kind of like a layered question I have, which is, I know from stories about miscarriage that women are reluctant to share those stories, and that the percentages actually are much higher than a lot of women going through it until they start having the conversations. That seems to be the case here too. So I guess for Christine and for the doctor as well, why do you think that is also? And and then, talk more about this medical gaslighting and this idea that, you're made to feel like you're responsible for the pain. I'm curious about, both of those things. I guess we'll start with Christine in terms of, your experience in this.
Sure. So I definitely experienced a lot of it. I didn't really start advocating for myself until my 30th birthday, which was about 4 years ago. And one of my friends got diagnosed. She was having some infertility issues. And that's another really big factor about endometriosis. And that's how a lot of people find out that they have it. And I let her have the excision surgery first and see how it went. And then I started looking into it more. I let her be like my personal guinea pig. And once it was kind of a combination of events. It was like my 30th birthday and me realizing this is not how I want to live the rest of my life. It was seeing her get diagnosed. And it was also just one particularly really bad ovulation cycle where I woke up from a dead sleep in the middle of the night and had to like bolt to the bathroom and just spent the rest of the night throwing up. Like I made myself a little nest and just kind of spent the night on the floor. And I was like, I can't live like this. I just can't. So that was kind of what inspired me to really find a doctor that listened. And when I did find my first endo specialist, who now is in New Jersey, actually, Joe, he listened and was like, yeah, this seems exactly, I think you diagnosed yourself. You did it. Good job. Like that's what you have. And same thing, like when I went to go talk to Dr. Griffin, he goes, yeah, this is very typical for what I see normally. As far as the gaslighting, I think the biggest one that I found was with my previous OBGYN, who's retired since all of this got diagnosed. When I was taking the bar exam for the first time, I had my period, which was a really unfortunate combination of events. Because, you're stressed and it's a huge test and everything. And you have to carry everything that comes into the bar exam with you in a plastic bag that they have to search. So I, of course, had like enough pads to, I don't know, use for a normal person for a week for one day. And I spent like 20 minutes throwing up in the bathroom during the bar. And when I brought this up to my OBGYN and I was like, this is not normal for a 27-year-old woman, she was like, you must have just been anxious about the exam. I was like, I can tell the difference between pain and anxiety.
Yeah.
There's a difference. Sure, I was anxious about the exam, but the biggest part of my anxiety came from the fact that I knew I was going to be taking this test, not feeling well. And so I've experienced kind of a lot of that, especially in my former OBGYN practice. Like I had another doctor tell me that there was no way he would compromise my fertility at my age because he has 4 children that he loves. So why wouldn't I want to experience that? And I'm like, but I know I don't want them and I don't want to have a period anymore. So like, why can't you divorce what you want in your mind with what other people want? And also you didn't give birth to those 4 children. Your wife did.
So let's just be honest there.
Yeah, be honest. Like you didn't have to go through the pregnancy 4 times and the delivery 4 times.
Right.
So it happens a lot, unfortunately. And it's happened. I have a blog now about endometriosis, and I've diagnosed at least like 5 or 6 friends of friends from all over the country who are like, I thought I was crazy. People have told me that I don't feel well and it's just my low pain tolerance. So that's kind of how I channel the frustration and the anger that I have in what happened to me in my 20s and my teens is by helping other people so that they don't end up in the same situation that I did, suffering the way that I did.
Yeah.
So.
And Dr. Griffin, like, what are your thoughts of like, why is the only reason that you can officially diagnose this through surgery? Like, why hasn't there been more research and more things done to be able to diagnose this and to treat it properly?
Yeah, it's a great question. It is challenging because it's endometriosis is a native cell to our body and it's just displaced. So it's not that we're trying to test for a new or a disease process that doesn't exist in a normal healthy person. It's trying to just find that they're in the wrong location. So it's a little challenging. Now there's certain things you can tell ahead of time. Sometimes feedback there. Sorry. Sometimes the endometriosis grow on the surface of the ovary. You guys getting that too? I don't know if you're hearing that. But it sometimes grows on the ovary in such a way that it forms a cyst called an endometrioma, and has a very specific appearance on an ultrasound. So there are certain imaging studies where we can see it, but other studies that have tried to look at this, like CT scans, MRIs, looking at different thicknesses outside of the vaginal rectal wall. There's certain things that have been correlated to it, but nothing where we can say with certainty that you have it. There's a few promising things out there now. There's an endometrial biopsy. So it's basically sampling some of the cells that are in the normal uterine lining and looking for a protein called BCL6. And so that's a substance that tends to occur more in patients with endometriosis. So if that's present, it gives us a more of a suspicion that it's there. I find, though, by the time at least that I start talking to patients about it, there's enough clinical suspicion that really warrants doing the laparoscopy. And I think what Christine experienced is pretty common. Most patients going into the surgery, there's this initial anxiety of, oh boy, I hope I'm not wasting everybody's time. If this isn't there, then I'm never going to think I'm an idiot. I'm just blowing this out of proportion. And we just try to be as reassuring as we can. Look, the story that you're telling really adds up to this being endometriosis. And then I think that sense of relief that Christine described after surgery is also very common. They're actually, even though we're diagnosing them with something that's going to be a chronic issue for them, it's relief to know that, all right, I'm not crazy. This is actually real and something's there. So those two, on both sides of the surgery, those sort of feelings are very common.
Even after, so I knew I had endometriosis when I saw you the last time, and when I was waiting for surgery and speaking to the resident that helped with my surgery, that's what I told her. She was like, do you have any concerns? And I'm like, I'm just so scared that he's going to cut into me again and there's going to be nothing there, and he's going to be like, you were a whiny little baby this whole time. Why did you make me give you a hysterectomy? And she's like, I have your report from your previous doctor. You are already diagnosed with this. You have it. But it's so hard to break that cycle mentally where that there's something wrong. But enough people that have studied this, and our doctors are telling you that you just have a low pain tolerance, that I was convinced I was going to wake up and someone was going to be like, well, thanks for wasting Dr. Griffin's time. Which didn't happen. The resident that I spoke to was the kindest woman on the planet. She was wonderful. So it was really great to have that. But I needed that reassurance, and I already knew I had it. So,
yeah, and I was reinforced to patients that either way, if we do the surgery, we're going to have an answer. We're either going to find it, or in the absence of it, at least we know it's not, and we can focus our attention elsewhere. So it's and going back to the questions of the incidence of endometriosis, 1 in 10 is sort of a number that's thrown out there. In my experience, it's much higher. I think once you start looking for it and you kind of understand who's more at risk for it, you tend to find it in more patients than you'd suspect. And I'm a fertility specialist, so I see a lot of patients who are coming through looking for answers as to why they can't conceive. And about 30 to 40% of our couples actually wind up being diagnosed with unexplained infertility. If they passed all the tests that we can throw at them as far as a reason why, and we find that the diagnosis exclusion is that we don't have an explanation. Most of those patients end up that endometriosis is the explanation. So a lot of those patients, even if they're not having significant symptoms, will eventually do a diagnostic procedure and often make that diagnosis for them.
Sorry, as a feedback, sorry, it's happening to all of us. I'm so sorry. I hate technology, but my question to follow up to that, I guess I have a 2-part question also. It seems like there is a hereditary component to this. Maybe I'm not sure if that's correct or not. But if it is, that's the kind of thing that I'd be curious about, because I have a daughter, and because I don't know that, my mom experienced it. She's not with us anymore, so I can't ask her. None of my sisters have ever mentioned it, but I'm curious about, the hereditary component of it. But I'm also curious, I don't know if I missed it, but why does it make women infertile? Because I'm not sure if I'm clear on that.
Sure. So the first question, yes, it's a great question. There is a hereditary component. So we tend to find, there's no endometriosis gene that we can follow through the family tree per se, but we tend to see it cluster in families, whether it's sisters or mother, daughter, or a cousin. It's usually where it's not the first time that it's popped up in the family tree. And why that is, why certain women get endometriosis and others don't is another question we're trying to answer. The way that we feel endometriosis gets to where is the most common way is what's called retrograde menses. So every month when the lining sheds, the majority of the menstrual blood exits through the cervix to the outside world. But we know most women, endometriosis or not, have some percentage of menstrual blood that backflows through the fallopian tubes and then spills into the pelvis and abdomen, where those cells can then take hold and establish a blood supply. So, again, most women have retrograde menses, but not all women have endometriosis. So we think there's some sort of environmental cue or more likely a genetic predisposition that just allows that process to set itself up. And from a fertility standpoint, it's multifaceted as to how it affects fertility. And so the most obvious is that sometimes endometriosis, the implants themselves, can affect the fallopian tubes, the ovaries, cause this physical miscommunication between the egg and the fallopian tube, whether it's scar tissue or just direct obstruction. But we'll just see a physical blockage of communication between the sperm and egg or the embryo and the uterus. But sometimes we'll see that those are perfectly clear and there's no real physical manifestation, and there's some other hormonal processes that play out. We can see reduced egg quality and egg number. Sometimes we'll see a premature ovarian insufficiency, we call it, where we'll see a depleted number and quality of eggs, even in a young woman. And then the other is that it can actually cause, endometriosis can cause the normal lining of the uterus, the normal endometrial cells, to misbehave as well. So we can see it, women develop something called progesterone resistance. So normally progesterone is a hormone that's made in the second half of the cycle as an embryo is getting ready to implant, that helps the lining prepare and then support the early pregnancy. And some women, they're making perfectly normal amounts of progesterone, but it just can't exert its effect on the normal lining. And so it prevents the embryo from implanting in the first place. So a lot of times we get everything in the right place at the right time, but the lining is just not set up to function normally because of the endometriosis. And when we go in and remove the endometriosis, you take away that inflammatory response and all those things get better. We'll often see improved egg quality and then higher embryo production. When we're doing it from an IVF standpoint, we'll see an improved number and quality of embryos that we're working with, and then we see higher implantation rates as well. So it can be a very correctable condition. And going back to Christine's case, a lot of times abnormal bleeding can occur with endometriosis for that very reason. Sometimes we'll see abnormal bleeding throughout the month, sometimes not in heavy forms, but more spotting or just bleeding that precedes normal menses. We'll see a premature breakdown of the lining that leads into full flow menses. And then in Christine's condition specifically, endometriosis can sometimes invade into the muscle wall of the uterus and then even communicate with the normal lining. It's a condition called adenomyosis, or in Europe, they just basically say it's endometriosis of the uterus. And that can cause more profound abnormal bleeding, heavy bleeding, and pain that really can't be improved without your hormonal suppression or removal of the uterus. So it sometimes takes a more aggressive approach to properly deal with it.
Christine, can you just describe the amount of relief that you have felt where, you've been dealing with this pain since you were 12 years old. I'm just curious, what does that feel like where you're like, okay, I have some answers. I'm not making this up in my head.
It was such a relief the first time to know that I wasn't making it up. And then shortly after I was diagnosed, initially back in 2019, one of my cousins was diagnosed. So it definitely runs in our family. And then I think I kind of just assumed I would be normal after that, right? Like I would have periods like my friends had where it was like, okay, it's annoying, but it's not stopping me from going on a work retreat or, ruining the bar exam or any of that kind of stuff. And I did try continuous birth control for a while, and I was still having breakthrough bleeding. And as I'm getting older, my mom had a stroke. So being on birth control long-term in your 30s isn't always advisable. So that's when I really decided, I want a hysterectomy. I just need to find somebody that will do it. And no one in my current OBGYN practice would do it. So I started Googling, and that's how I found Dr. Griffin. Most people are nervous, I think, before surgery. And I was so ready. Like, I remember sitting in the pre-op area being like, okay, let's I went into my consult with Dr. Griffin ready. Like, I prepared like a law school final, ready to like make the argument to him that I did not need a uterus anymore. And he was like, okay, you're old enough to make that decision yourself. Like, you've thought this through. I'm fine with it. And it was such a relief that I didn't have to keep doctor shopping, which is something I didn't really want to do. I didn't have time to do. It was right before an election too. It was last August. So now it's such a relief knowing that how I feel on any given day isn't going to be dictated by this. How much work I get done on any given day isn't going to be dictated by this. I mean, the surgery was super easy. I was fine within like a week. I tried to go back to work like probably earlier than I should have. And then some of our coworkers were like, girl, you need to go like lay down. You just had surgery. So I think within 10 days, I was fine to go back to work. And even like the pain didn't compare to normal period, which I think is just really astounding. And now I can plan a life without having to worry about feeling sick anymore. And it's just been really incredible to know that there was something wrong. Even knowing that I had endo, after my last post-op appointment with Dr. Griffin, and he mentioned the adenomyosis, I was like, okay, so there were multiple things wrong. And correct me if I'm wrong because I'm not a doctor, but I'm assuming like if I had just gotten an excision surgery, I still would have had issues, right? Because of the adenomyosis. So all these people in my life that were telling me I was being dramatic for wanting a hysterectomy at 33, I really felt like validated after I spoke to you the last time because it wouldn't have helped, right? Compared to.
That's right. It is really, adenomyosis is a unique condition in that sometimes it forms a more organized area that we can remove with preservation of the uterus, but in most cases it's more diffuse. And so really a hysterectomy outside of hormonal therapy is the only surgical approach that's going to be effective for us. So, I think, it is very paternalistic. I think sometimes sowing some doubt and making sure a patient is fully considered all their options is appropriate. But most patients, when they've gotten to this point, have really exhausted all their other opportunities and feel really confident, in their decision. I have yet to do a hysterectomy in someone who's later had regret or, felt bad. In fact, I think they're among my most grateful patients that finally this was done for them. So, but it's all about meeting the short and long-term goals for each individual patient, and everyone, no one's the same. Everyone needs something different.
And Dr. Griffin, just, we'll wrap up in just a few minutes. Like, I'm curious from your perspective, what advice do you have to people to advocate for themselves? Because, and I'm a mom, and I remember when my kids were babies being told, like, you're with the babies all the time. So you have a good idea of what's best for them, or you can advocate for them because you're with them. But, we live in our own bodies. So just like from a medical professional, how can we advocate for ourselves when we're like, I know something's wrong. I live in this body. I know it.
Yeah, I guess, well, first and foremost, thank you for setting this up, because I think just educating people is probably the most powerful thing we can do, just to let them know, hey, this isn't normal. You don't have to live like this. Even if you're being told that this is normal, if it's disruptive to your day-to-day life and plans, then it's likely something else going on. And I think, if your doctor isn't being accommodating to your needs, then it's not wrong to I think, traditionally people tend to trust their doctors and do what they say. But if you're kind of running into the same wall and over again, I don't think, I would advocate you step up for yourself and find a new doctor, someone who's going to listen to you and help you meet your needs. So, and there are, I think some physicians, their focus is on obstetrics or certain forms of GYN, and endometriosis isn't something that everyone does. In our field, we now fortunately have a separate fellowship program. It's called MIGS, or minimally invasive gynecologic surgery. and a large focus of that is now on dealing with endometriosis. So there's going to be more and more subspecialists like myself who are specifically trained in doing minimally invasive surgeries to address this condition. So I think if your general OB/GYN isn't satisfying that need, there's going to be some providers near you that are going to be able to help out and listen.
Yeah, that's great. Christine, is there anything else you want to wrap up with or just share from your own experience?
I think the biggest thing that I would tell people is to compare what you're going through with friends. If you have a group of lady friends, talk about your period. I mean, I know back when I was in middle school and I first got my period, everybody was, hiding pads and tampons up their sleeves to go into the bathroom. Like that's a classic move that we all did, right? And don't talk about it.
Mhm.
Talk about it. Because if you don't have anything else to compare it to, bleeding through 8 pads in a 6-hour day is normal for you. And it's not, and you don't need to live like that. And there's a lot of resources to Google endometriosis specialists in your area. That's how I found Dr. Griffin. That's how I found my doctor before that. And I think that it's really important to find somebody that is a specialist if that's what you suspect that you have, because even a lot of OBGYNs don't know what to look for. So I think it's super important to make sure that you know that you're seeing a specialist and that you're talking to people so that you know what you're experiencing isn't normal.
I think that's such a great point. And I have a young teenage daughter as well. And I want to leave that communication open. And like you said, talk about it. It's not taboo. It's just what our bodies do. Like, I don't understand where that comes from. It's not anything to be embarrassed about. But yeah, I think that's great advice. Talk about it and I don't know, make it normal conversation, I guess. I don't know what else to do. Joe, do you have anything to add before we go?
No, and I apologize. Apparently, it's my speakers that are making me sound like a robot. So if that's happening right now, I'm very sorry. Um, but I'm just grateful for the conversation. Honestly, Christine, I'm so grateful that you shared this experience and your story. Dr. Griffin, I'm so grateful that you shared your expertise on this issue. I think the number one thing that I'm taking away is that I'm sure women go to you and they feel for the first time like they're seen, that they're not crazy and like this world can make us all feel crazy all the time. So to have for Christine to have found doctors who could make her feel like she had answers and felt seen, and for other women to be able to have that too, so important. So many noises coming from my computer. So I just wanted to thank you because I didn't know enough about this topic. I admit that freely, and I want that to not be the case for my daughter and for other women out there who might not know what's going on with their bodies and they might feel crazy too. So I'm going to mute myself because I'll sound like a robot, but I wanted to thank you both so much for joining us for this today.
Yeah, thank you for taking the time. I think this could open up the conversation for people. And before we go, Christine, can you just let us know how we can find your blog?
Sure. It's myendometriosisjourney.com.
Okay. Yeah, so check that out. There's a lot of great information. I'm a proponent of sharing stories. It makes us feel less alone. So thank you, Christine. Thank you, Dr. Griffin and Joe. And thank you, everybody, for tuning in. So have a great afternoon.
Thank you very much.